morning, everyone. First of all, I must thank the President and the Council of the Candy Society of Medicine for inviting me to deliver this lecture today. I'm indeed take it as an honor, and it's my pleasure to be here with you today. The topic I chose to talk to you is dyslipidemia in children, a silent killer. Now, dyslipidemia is generally asymptomatic during childhood and adolescence, in spite of the pathological process being continued, and track into adult life, when it can manifest suddenly, even without any warning, as a catastrophic cardiovascular event at the prime of a person's life. Therefore, the scope, the focus of the world NCD experts have now moved towards addressing the risk factors in childhood. Well, ladies and gentlemen, as you may know, atherosclerotic cardiovascular disease is the leading cause of death worldwide. And dyslipidemia is identified and recognized as one of the most important etiological factors. And dyslipidemia has been found by many epidemiological studies that it begins in childhood, maybe very early in childhood as 2 to 3 years of life. And it is largely preventable. That is why it is important and relevant to us as pediatricians, because a lot of studies have shown identification by screening children and finding who are at risk of developing dyslipidemia induced atherosclerosis. If we maintain a low-risk lipid profile during childhood through to adolescence and young adulthood, the risk for cardiovascular events can be exceedingly controlled. So looking at the situation in Sri Lanka reported by the World Health Organization, we see about 34% deaths among adults due to cardiovascular events. So this is just mortality. We are not talking about the morbidity figures. So it's a significant proportion of deaths among adults. So the roots of some of these patients could have been in childhood. So with that background, I will be going through into my lecture, talking about the definition of dyslipidemia and who are the children at risk and how do we identify them, the screening guidelines which are accepted internationally, and then I will touch upon the management. Right. So by definition, dyslipidemias are disorders of lipoprotein metabolism where we see one or more lipoproteins elevated, like total cholesterol, LDL, triglycerides and non-HDL, with low levels of HDL cholesterol levels. So dyslipidemias in children could be hereditary. Dyslipidemias could be due to multiple factors. It could be hereditary, but not very common. Could be secondary to other primary medical conditions, or could be secondary to long-term medications like steroids. And most importantly, nowadays, dyslipidemias are related to unhealthy lifestyle. So we do have standards to interpret lipid profiles in pediatric patients, which are different from adult standards. I will be going into details of interpretation of lipid profile later in my lecture. This is just to show that we have cut points for borderline and abnormal levels. So in the pediatric community, we come across 3 basic types of phenotypic types of dyslipidemia. The commonest out of these 3 is adiposity related hypertriglyceridemia, which is related to overweight. In an overweight child who has high triglyceride levels with low HDL cholesterol levels. This is the commonest phenotype that we see among children. And secondly, we see two hereditary types as well. So one is a normal looking child who is asymptomatic, otherwise active, but has high LDL cholesterol levels, and there is strong family history of early heart disease. I will talk about the family history a little later on. So these children belong to the group of familial hyperlipidemia or familial hypercholesterolemia. The third category, again they are normal children, asymptomatic. They have high LDL cholesterol, and in addition to that they have high triglyceride levels as well with low HDL. And again there may or may not be family history of dyslipidemia, and these children belong to the group of type 2 combined familial hyperlipidemia. So these are the three common types that we come across in pediatric population. So I have tabulated that for you to compare. So adiposity related hyperlipidemia, which is the commonest, is characterized by high triglycerides, low HDL, but they also can have mildly elevated LDL cholesterol levels, which does not require treatment, which is not up to the level of treatment requirement. And they have high BMI, and generally they don't have family history of any premature atherosclerotic heart disease. And then the second category, familial hypercholesterolemia or hyperlipidemia with high LDL. So this is the hallmark. And again, normal children, but they also can have obesity or overweight. So those factors, the secondary factors, can aggravate their clinical condition and they can manifest earlier. And the third type is type 2 combined familial hyperlipidemia, where they have high LDL plus high triglycerides and low HDL. Okay, so first we'll talk about the adiposity related dyslipidemia, which is the commonest that we encounter in our general practice. So it is prevalent among 42.9% of obese or overweight children, and it contributes to the highly atherogenic cluster of manifestations which we call metabolic syndrome, where the key components are central obesity, that is increased waist circumference or abdominal obesity, dyslipidemia, hyperglycemia and hypertension. So this cluster is considered to be highly atherogenic. Right. So the primary inherited dyslipidemias, again there are various classifications. They are inherited either via a single gene or via polygenic inheritance. And again, as I told you earlier, the manifestations can be exacerbated by secondary causes like high BMI, unhealthy lifestyle, and also by long-term medications and so on. So diagnosis is generally with history, with the evidence of premature heart disease in family members, and also examination is helpful with the lipid profile manifestations, and sometimes the serum appearance, the lipemic serum, points towards the hypertriglyceridemia and hyperchylomicronemia. Examination, of course, is helpful in homozygous hypercholesterolemia, where you may be able to see the eruptive xanthomata. I will show you a picture in a while. Now, looking at this classification, our familial hypercholesterolemia falls into the type 2A category, and combined familial hyperlipidemia belongs to the type 2B category. So these are the two common ones that we come across. So others are extremely rare. Right. So coming on to familial hypercholesterolemia, it is quite common. Prevalence is about 1 in 500. The heterozygous, the familial hypercholesterolemia is the commonest type. And most children, as I told you, are asymptomatic during childhood unless we screen and find them, or sometimes children undergo part of the family cascade screening when a family member dies prematurely due to heart disease. So the hallmark would be high LDL with premature cardiovascular disease in a parent or a grandparent, aunt or an uncle. In males, it has to be before 55 years, and females before 65 years is considered as the high family risk. So these are the eruptive xanthomata, which we can see in homozygous patients. Right. So familial combined hyperlipidemia is the third category, as I told you. It's an autosomal dominant inheritance. There are various phenotypes. The commonest we see are these manifestations. I have told this earlier. And again, prevalence can be even higher than hypercholesterolemia in certain communities. Okay, so I'm talking about hypertriglyceridemia because this can be an isolated manifestation in children without associated increased total cholesterol or LDL. Even then, hypertriglyceridemia is considered as an independent risk factor for coronary artery disease. And also, when the levels are very high, like about 800 milligrams per deciliter, there is a high risk of pancreatitis. And isolated hypertriglyceridemia is usually observed in these conditions like obesity, diabetes, chronic renal and liver disease, endocrinopathies like hypothyroidism, Cushing syndrome, and also in patients who are on long-term medications like steroids, growth hormone therapy, androgen therapy, and beta blockers. Okay, so how are we going to identify the children who are at risk of dyslipidemia? Right. So there are international guidelines under two categories. The first is targeted screening of high-risk children, and also the second category is universal screening. I will talk about the targeted screening first because it's more applicable to our society. So targeted screening we can actually start very early in life if there are risk factors. So what are these risk factors? One or both parents known to have hypercholesterolemia or are receiving lipid lowering medications, or there is family history of premature cardiovascular disease. This is the criteria. And if the family history is unknown, like adopted children, or there is unexplained deaths in the family early in life, and then if there are moderate to high risk factors for premature atherosclerotic cardiovascular disease, I will go through these moderate and high risk factors in a later slide. So these are the guidelines laid down by in 2018 by American College of Cardiology and American Heart Association and many other societies for targeted screening. Right. So why 2 years? According to the lipoprotein maturation in childhood, all the lipoprotein levels are very low until about 2 years of age. So during 2 to 3 years of age, the levels reach close to adult levels. So that is why we screen at that age. We don't screen any child below 2 years of age. I will tell you how the lipoproteins mature according to the age in a little while. Right. So the universal screening, this is for all children in general with or without any risk factors. It's recommended beginning at 9 years of age. The range is 9 to 11 years. All children have to undergo their first lipid profile at this age. And if they are at acceptable levels, then the second screening is recommended between 17 to 21 years. So I will tell you why we have selected these two age groups. And then screening should be repeated every 5 years after the age of 21 years. And earlier screening is recommended if the circumstances of these children change. For an example, if they develop an autoimmune disease and start on long-term steroids, or if they become hypothyroid, we need to screen earlier. Right. Okay. So the lipoprotein maturation, like a child goes through the development, puberty and so on, the lipoproteins also mature with age. So there are two peaks in a child's life. First peak is between 9 to 11 years and second peak is between 17 to 21 years. The levels are lowest during infancy and up to 2 years. Right. So we are trying to catch these two peak ages to see whether their levels are at in the range of risk. So these are the values, the international standards to interpret the lipid profile. So these are the acceptable levels. I'm not going through the figures here. We have borderline figures as well as abnormal cutoff points as well. And for triglycerides, since there is a very high peak at between 10 to 19 years, we consider it as separately, 0 to 9 years and 10 to 19 years. I'll talk about the significance of these when we start talk about indications for treatment. Right. So when we do a lipid sample in a child, we are looking at these components in a lipid profile. So the total cholesterol levels, and then these components which include HDL, LDL cholesterol, and the remnants we are not going to interpret much in pediatric patients. So they are all included if we check the non-HDL cholesterol levels. And we can also check the apoprotein levels as well, but not universally accepted for pediatric patients. Right. So now I'm going to talk about whether we need to do a fasting lipid profile or a non-fasting lipid profile in children. Now, to talk about that, I would like to show you how the lipoproteins vary after a meal when a child starts fasting. So generally the total cholesterol, HDL, and the non-HDL, those levels do not vary markedly. There is no significant variation, but it affects the triglycerides and LDL cholesterol levels. Therefore, in a non-fasting sample, it's a bit difficult to interpret triglycerides and LDL levels. And therefore, fasting lipid profile is considered superior to a non-fasting sample if we are going to assess a child at risk. So as I said, in a non-fasting sample, we can reliably interpret total cholesterol, non-HDL cholesterol and HDL. But it's not reliable to interpret triglycerides and LDL cholesterol levels. So if we do a non-fasting sample, which is advised, for universal screening and children without risk factors, if the total cholesterol level is more than 170, we need to repeat it in about 2 weeks' time and average the value. If it is still high, we have to go for a fasting sample. So generally, the non-fasting lipid profile is suitable for children without risk factors, that is for universal screening, and also for monitoring statin therapy, if we are using the monitoring tool as non-HDL cholesterol. Now, non-HDL cholesterol represents all the cholesterol, all the components except HDL. But however, the scientists say the representation of LDL in the non-HDL cholesterol level is not up to the standard. So therefore, there is a controversy in using non-fasting, in interpreting non-HDL cholesterol in a non-fasting sample.